What we do have here is Bob Breaky. He's a physician with Integrated Health Associates. He's not only just a physician with them. Bob is the Integrated Health Associates Medical Director of Health Plan Relations. He is the chairman of the board for this physician organization. They have over 240 PCPs, is that right? Physicians. Okay. He's in charge of their quality improvement committee. And I've sat on had the privilege of sitting on a couple committees with Dr. Breaky in the past, and he has an awful lot of information that he can share with us because he's a daily practicing physician on top of his committee responsibilities. The Ann Arbor theme came up a lot. You must be like Mr. Ann Arbor. He went to high school in Ann Arbor. He went to undergraduate at University of Michigan, medical school at University of Michigan, and got confused and ended up in family practice residency in Wisconsin, at the University of Wisconsin, but then made his pilgrimage back to the hallowed grounds. He also was voted Best Doctor in America, and the Best Doctors in America from 2007 to 2012. Now, I'm not always sure about those, but I actually trained in Ann Arbor, and I can say that Dr. Breaky is one of the best doctors in America, and we're happy to have him here. So.
Sorry. Give us 2 of these microphones to work with. Thank you. Thanks, Steve. When Steve asked me to talk about quality and effectiveness in 20 minutes, it's a big task, but I note that we all voted that as kind of most important of the various areas. And I think there's good reason for that, is that it overlaps and encompasses all the others as well. We know that if we practice good, effective, and efficient medicine, it's also likely to be safe. It's also likely to be patient-centered and have good outcomes that patients are satisfied with. So it was with pleasure that I accepted this invitation to join you, and thanks for having me. And here's the other clicker. So my talk on an evidence-based approach to high-value screening and diagnostic testing relates mainly to the area where we as providers have the most control. And in January, an article from Annals caught my eye regarding the appropriate use of screening tests and helping to categorize those to those that are of high value and of cost conscious. As Dr. Flanders mentioned, that we've got, and Dave mentioned too, unsustainable costs make it imperative that we reduce costs while maintaining our high quality. And this is highlighted by the just cost per family that we see trend over the last several years and then projections over the next 10 years if we don't dramatically change what we do. And although most of these costs are paid by insurance companies, they're really paid by us, by our members of society, and the cost of the goods and services we have, and the cost of insurance, and a lot of the cost shift that we have. So we have to make changes. And the overuse of some, I'd say many, diagnostic and screening tests are important components of this unnecessary cost, and probably one of the most that we have one of the most control over. In fact, it's estimated that about a third of our healthcare expenditures are waste, and probably the biggest component of that is unnecessary care. A lot of that, which is unnecessary test ordering or procedures, which then, through false positives and others that we'll come back to, spawn more unnecessary care that never needed to happen, or results in additional cost to our patients and our society. So this is, again, the abstract from that article in Annals. The more judicious use of these tests will improve quality and reduce cost at the same time. Efforts to control expenditures should not only focus on the benefits, the harms, and the costs, but also the value of the diagnostic tests. That is, do they really bring benefits that are worth their costs and their harms? So examples from the article, retroviral care for HIV clearly makes a big difference, childhood immunizations, and then low-value tests, although they're not very expensive. Pap smears every year are unnecessary versus every 3 years. Pre-op chest x-rays in asymptomatic healthy patients. The work group then identified a group of 37 commonly ordered tests that do not reflect high-value care, again, in an effort to help to identify where we can make changes and improve care. And these are just some examples of those 37. Screening ECGs, annual lipid screening, bone density screening less than age 65, Pap smears over 65 or after a hysterectomy, screening for prostate cancer over 75, and we'll come back to this because evidence has changed even since this group came out, x-rays for low back pain, pre-op labs in healthy patients for elective surgery, and then CT or MRI for migraine without neurologic findings. Again, just examples of several of the areas where there was consensus among this group that these could come. And where the evidence comes from, again, back to Pap smears, of course, the USPSTF guidelines have kind of gone on beyond the ACOG guidelines from 2009 to say really that every 3 years is fine from age 21 to 65, graded in A, meaning excellent evidence that that does help to save lives and improve outcomes, whereas a D grade, of course, means does more harm than good. Doing Pap smears on women under 21 where it's likely to regress, or for a TAH for benign disease, or for low-risk women after age 65, and then do not do HPV screening less than age 30 as well. So again, just examples, and then I mentioned the PSA, which has hit the national news and all the controversy, which initially back in 2008, evidence said AFK after 75 with limited lower lifespan, and then of course just this year the USPSTF confirming grading a D for PSA screening for any men of any age. So I'm now actively discouraging PSA testing. It does more harm than good for our patients, and is a great example of one that adds cost, downstream cost, false positives, and an area where we can work with our patients and our systems to improve care. So the suggested principles from this article: do not perform diagnostic tests that will not change management. Back to Med School 101, Dave and I were talking before the meeting. We were all taught this, and yet I think we have to remind ourselves of the importance of making sure, will this test change what I do? And attached to editorial to this, they also said, you also have to see whether the test may have already been performed. So often it's easier to just repeat the test than to go find and look it up, what was done in the ER or by a primary care colleague. So a lot of repeated tests that won't change the management because you already know the answer to that need to be looked at. Also, when the pretest probability of the disease is low, the false positive rate is high. Common example for that, if the incidence of a given condition is 1 in 10,000 in the population, and you have a test to detect it that's 99% sensitive, that means that when you run the test on those people, only 1 out of 100 positives will be a true positive. You have to really begin to think in screening tests where you're screening large numbers of people. Will this make a difference that is worth the cost of those 99 false positives and the associated cost workup and evaluation of those that goes along with that? And then the true cost must include the downstream costs and risks and potential harms. And again, I think that's one of the big issues with respect to the PSA testing for people with indolent disease that would not have caused a problem in their lifetime, but of course end up with treatment for those cancers and the associated harms and morbidity even mortality that they incur from that. Dr. Flanders also recommended or talked about the choosing wisely. I think this is a concurrent initiative. We didn't coordinate our talks, but the same kind of sense here is to help us be better stewards and improve effectiveness and efficiency of care by bringing from the physician organizations themselves, where do you think we can improve care, including effectiveness and efficiency? I was at the American Academy of Family Physicians meeting last year. Dr. Mike Lefevre, the co-chair of the USPSTF, gave his annual update. And he talked about how initially the HEDIS criteria back in the 80s were designed around making sure that enough was done. There was all a concern with the HMOs that you'd be withholding care and not giving what was needed. But there are very few kind of what is being too much kind of things. And he said, you'll be seeing more of this come out, kind of foreshadowing for what they were coming out with in this year with cervical cancer and prostate screening. But this is now coming out from our specialty organizations. Again, the group here, and just to highlight some from the American Academy of Family Physician, don't do imaging for low back pain in the first 6 weeks. It doesn't improve outcomes, but does increase costs, and this is a huge reason for visits to us as family physicians, as we know. Don't routinely prescribe antibiotics for mild to moderate sinusitis unless it's 7 or more days, clinical picture. And I know we've got a question for this, so I can't really tell the answer. He's got this as one of our questions. But many times these are viral infections. It becomes convenient. It's what the patient wants, but it adds cost and doesn't improve value. Don't use DEXA screening for women younger than 65. Again, Dr. Paul Frame, part of the USPSTF, talked with me about this several years ago about how you may be able to pick up osteopenia sooner, but the issue is those women in that age don't fall as often. What you're really looking for is not just bone density, but improving outcomes through reducing fracture morbidity and mortality. Don't order routine annual ECGs for low-risk patient without symptoms. Extra cost and the downstream cost from working up those that may not be, never really needed it. And then again, back to pap smears, which we've already talked about. So these 5 come from the AAFP. Other groups are working through similar efforts, and I think we'll be seeing more and more of this as doctors rise to the occasion. So this is a conclusion back to the Annals article, as we have a significant opportunity to improve quality of care and lower healthcare costs by eliminating the use of tests that are unnecessary and in many cases even causing harm to patients. I close with Don Berwick's quote from his talk last year that we stand, though we do not choose it, at the crossroads of momentous change, threshold of majesty and frightened, fortunate or both, and the only way that Don can put it, we now have a chance to make what is possible real. I think that across the organizations, across Michigan, we've seen great progress towards improving value of care that we deliver along all 6 of the aims that Dave talked about. And thanks again for letting me share some of what our thoughts are on how we can do that as providers to help in what we order and do. Steve, thank you.
Thank you, Dr. Breaky. We just wanted to see how we're doing as a group overall. We don't have the same type of, obviously, integration as PCPs and as specialists as a group like IHA has. So we just kind of wanted to see just, how you practice. There's not a right or wrong answer with this. You might already know what the answer is. I haven't passed out the Choosing Wisely, but we have made copies available and we're going to pass those out. But one of the things that prompted this whole discussion today was the AFP article or the Annals article that came out. And then we've kind of built on that, and we started doing some things with EKGs, working with our cardiologists to develop guidelines, and then this Choosing Wisely campaign came out with a guideline as well. So we're looking at this as an organization. A 55-year-old Caucasian female presents to your office for her routine physical exam, which is required by her employer group. She's a non-smoker and physically active. What best describes your practice pattern? Obtain a baseline DEXA. The result's -1.5, so recheck every 2 years. Obtain baseline DEXA, result is -1.5, so recheck in 3 to 5 years. She's low risk, so just wait until she has Medicare, or refer her to a bone specialist. What would best describe the way you handle this? And if you're a pediatrician, how would you want your wife to be treated? That would work. Or a specialist. Or you, if you're female. Okay. 74% say she's low risk, so just wait until she has Medicare. The interesting thing about this for our organization is we probably have more forward-thinking physicians in the room today, but our utilization rates of bone density testing is much higher than other groups in the area. So trying to get these quality measures and these ways of practice taken to our entire organization is of huge value for us as a group. You have a lot of reflux, probably due to all the rapid healthcare changes going on. So you self-refer yourself to the local gastroenterologist. He does an upper endoscopy and diagnoses you with Barrett's esophagus. You start Dexilent because you like branded drugs. Next year, you have to follow up, or next year you have a follow-up and no dysplasia is identified. You then get a yearly EGD to monitor, get every other year, every 2-year EGD, one every 3 years. The fourth answer, no further endoscopy is necessary, or self-refer to the new Beaumont Reflux Clinic that does that new procedure. No further endoscopy is necessary. That's going to be in your handout. Actually, I believe the answer to that is every 3 years now. So 43% of you have that correct, and that's on the choosing wisely. We're going to pass that out. Now, our gastroenterologist colleagues may differ as well, and that's something that we need to probably work on as an organization. 54-year-old male presents to the office for knee pain after no interval health encounters for the last 3 years. After his last physical 3 years ago, he saw a cardiologist who did an echocardiogram which demonstrated moderate mitral regurg, and you again hear a grade 2 murmur and document that in the chart. He denies cardiac symptoms, and aside from dealing with the knee pain, you decide to order an echo to reassess the changes in the valve, refer to a cardiologist for follow-up, check an EKG while in the office, encourage him to follow up for a routine physical after this visit. And encourage him to follow up for a routine physical. Again, that's correct. And as an organization, we're overutilizing echoes. So we got to get this message out to our colleagues who don't come to these meetings. I think that's an important thing to do here. And a patient presents to the office with syncope, which was witnessed. There's no signs of a seizure reported. On exam, the patient has no focal neurologic symptoms. You decide to initiate some cardiac testing. In addition, you obtain a CT scan of the head, MRI with contrast, MRI with no contrast, or no brain imaging. No brain imaging is the correct exam. So we're going to be passing out those choosing wisely. If you guys want to go ahead and do that. We've got one other case for pediatricians because we didn't want you guys to feel left out. Dr. Schnauer, pick up your patient. Now, the pediatricians have not participated in